Very good evening to all who are watching. This is a pre-recorded video for commonly encountered case for your practical exams, that is splenomegaly, right? I'll present a case of splenomegaly, and then we'll look at all the pertinent points that are important for your exam. Okay, so without any further ado, let's start it off. So you have a 52-year-old lady who is from Trivandrum, who's a homemaker. She presents with complaints of pain abdomen since 8 months, early satiety since 5 months, and fatigue since 5 months. So the patient was normal 8 months back, was asymptomatic 8 months back when she developed pain abdomen, which was localized to her upper left side of the abdomen, which is insidious in onset, dull aching, non-radiating, continuous with no exacerbating or relieving factors. It was not associated with food intake or nausea and vomiting. The patient also developed early satiety 5 months back, which gradually progressed in degree over this period. The patient also noticed fatigue 5 months back, which gradually progressed in severity. So there's no history of altered bowel habits, vomiting after meals, blood and vomitus, or dark-colored stools. There's no history of fever, weight loss, or night sweats, swelling elsewhere in the body. There's no history of repeated infections, bone pain, bleeding manifestations, blurring of vision, or headache. There's no history of similar symptoms in the past, no known comorbidities, and no previous history of surgery, and no previous history of malignancies. Personal history, there's decrease in appetite, bowel and bladder functions are normal, and there are no known addictions. Obstetric history, menarche at 13 years, menopause at 48 years. LMP was, last LMP was 5 years back, and she has a score of P2L2. Right. The patient is not on any regular medication. So based on the history, we have a 52-year-old lady with no known comorbidities who presented with a history of pain in the upper left side of the abdomen since 8 months, which was progressive. And she also had early satiety since 5 months and fatigue since last 5 months. So based on the current history, right, you have a patient who's presenting with pain in the upper left side of the abdomen associated with early satiety and fatigue. So based on this, I would like to give a differential diagnosis of a myeloproliferative neoplasm, uh, could be a CML. Another DD I'd like to give is a GI malignancy, right? Could be a CA stomach or could be a CA colon. Now, once you have given your DD, the examiner, of course, will ask you, what are the points in favor of your DD? What are the points against your DD, right? So let us quickly go back to the history here and see as to what we're dealing with. Okay, so this particular patient had a pain abdomen, right? Now, one important point here is the localization of the pain. The patient has said that's in her upper abdomen, more towards the left side. So we need to look at the upper abdomen. We're talking about the right upper quadrant, the left upper quadrant, and the epigastric area, right? So what are the pathologies or the organs that could be affected in terms of a malignancy? So the right upper quadrant, you have the liver, you have the colon, the hepatic flexure of the colon. The left upper quadrant, you have the spleen, the splenic flexure of the colon, and the body and tail of the pancreas. The epigastric area, you have the stomach, duodenum, and pancreas, right? So those are the organs or that could be affected by a particular malignancy, right? And since this is a medical oncology exam, we are going to only deal in terms of malignancies. So localize the pain. What could be the organs or structures that could be affected, right? In this particular case, it is a left upper abdominal pain. So it could be a splenic mass. It could be a colonic mass, right? Splenic flexure of colon could be affected. It could be the body or tail of the pancreas. It could be a stomach lesion that is also, getting over into the left upper quadrant. So all these could be possibilities, right? Now, let us rule out some of these DDs, right? So, when you're looking at stomach and GI, we have clearly mentioned here, right? Based on, we have ruled out a history of GI symptoms like altered bowel habits, vomiting after meals, blood and vomitus, dark colored stools, right? So all these could point more towards a GI malignancy, but we have ruled these out. Another thing is, severe weight loss, right? So this patient does not have a history of severe weight loss, which can also be once again seen in a GI malignancy, for example, a CS stomach. So, ruling out that in your negative history puts the dial more towards a splenic mass, right? So left upper abdominal pain could be splenic, could be GI. but we have ruled out the GI symptoms, that we have asked for, we got a negative history for the GI symptoms. So that moves the dial more in favor of a splenic mass, right? Based on the localization. Of course, in the left upper quadrant, upper left abdomen, you also have the body and tail of pancreas, but the pain in this case is not radiating towards the back. It does not increase. There's no nausea and vomiting associated with, the pain, and it's the pain does not worsen after meals. There's no associated jaundice, although that is more commonly seen with head of pancreas. But yeah, all these features, you know, put CA pancreas, behind in our TTs, right? So we have ruled all that out in our negative history. Now, the next thing that we are moving on, right? So the next thing that we rule out here is, so once we have ruled out GI malignancy, that is our second DD. That's why we put it in our second place. Another thing that we can rule out here is uh, whether this, we are going more in the favor of splenomegaly, right? So whether this splenic mass is associated with features suggestive of lymphoma. So are there swellings elsewhere in the body? Nodal swellings elsewhere in the body. Is it associated with B symptoms? So we've ruled that out next, right? By showing that there's no history of B symptoms or swelling elsewhere in the body. So that's how we can rule out lymphoma, because many lymphomas are associated with splenomegaly, right? Now, once we have ruled that out, now we need to ask for negative history that points towards, okay, we are looking at myeloproliferative neoplasm. We're looking at possibly most commonly it is CML, right? So we need to look at the history suggestive of what phase of CML it is, right? So if there's repeated infections, right, neutropenia, if there is bone pain, if there's bleeding manifestations like thrombocytopenia, if there is hyperleukocytosis with, that you see along with the increase in blasts, you might have blurring of vision, headache. If it is a male patient, you might have prolonged erections. So all these negative histories, it points away from a advanced phase of CML, right? So we have ruled out the other DDs, GI malignancies, CA pancreas, it could be, we have ruled out lymphomas, and now we are ruling out, an advanced state of CML, because that is our main DD, right? So that is what all this negative history means, and that's why it's all important. This is what you need to tell your examiner when he asks you, why do you go for a DD of myeloproliferative neoplasm? You're saying it could be CML. So these are the points in favor of that DD. The points in favor against a GI malignancy, I've also told you, right? Possibly they could sneak in a tail of pancreas, a body of pancreas. The points against that also I've told you. Associated lymphoma, the points against that I've told you. When I mentioned DDs, just mentioned two. What else could it be? You mentioned the other ones that I told you. Okay, but we have ruled those out. We have not ruled those out accurately, but rather we have, there's less possibility of those other DDs based on the negative history that we have elicited. So that is why we ask these particular negative history. Okay, right. So, now at this point, we are suspecting a myeloproliferative neoplasm could be a CML. In other words, we are looking at, could it be a splenomegaly, right? In a myeloproliferative neoplasm. Although you need not mention that at this point, at the DD, you can just mention myeloproliferative neoplasm could be a chronic myeloleukemia, which is the most common, right? The incidence is around 2 per 1 lakh population. Another thing in favor of CML, it could be the age of the patient. She's in her 40s, right? Whereas in the Indian population, it's seen in the 30s and 40s, right? CML. Whereas GM malignancies are seen more towards the fifth and sixth decade. So that's another thing that could, push your diagnosis towards a CML. Now, moving on with the examination, the patient was examined in a well-lit room with considered female chaperone. She's conscious and oriented, ECOG score of 1. There's slight pallor present. There's no palpable generalized lymphadenopathy, including the supraclavicular nodes, because like we said, GI malignancy was a second DD, right? So SC nodes also need to be mentioned. So no gum hypertrophy, gum bleeding, no pedal edema. Gum hypertrophy and gum bleeding seen in CML with a myeloid blast crisis could present like that, right? Vitals are stable. On inspection, the abdomen is flat, umbilicus is central and inverted. All quadrants move equally with respiration. There's no visible lump or fullness in any quadrant. There's no engorged veins, pulsations, or peristalsis. There's no visible cuff impulse. Palpation, there's no tenderness or no local rise in temperature of the mass. The spleen is palpable 10 centimeters below the left costal margin, extending downwards and medially, firm in consistency, smooth surface, moves with respiration. All the borders are felt except for superior borders. The splenic notch is felt and it's approaching towards the midline. The mass is non-ballotable. There's no hepatomegaly. There's no other palpable mass elsewhere in the abdomen, and there's no pulsations felt. On percussion, there's a dull note felt in the left hypochondrium and the lumbar region. There's no shifting dullness, and a normal liver span of 12 centimeters is seen. Rest of the other systems are normal on examination. So, in summary, you have a 52-year-old lady, postmenopausal, with no known comorbidities, not on any medication, present with complaints of left-sided upper abdominal pain since 8 months, early satiety since 5 months, and fatigue since 5 months. And on examination, she is found to have pallor as well as massive splenomegaly, right? So now here you have more concrete evidence. You have examined the patient. You have now directed, um, you have further, firm in your DD here because you have elicited that the patient has massive splenomegaly. So at this point, you can stick to your DD. I would like to consider my differential as a myeloproliferative neoplasm, most commonly a chronic myeloid leukemia. Based on the history and examination, I'd also like to say that it is could be most likely in the chronic phase, although I need further workup to prove that. You can say this at this point. Okay. Now, there are various questions that can be asked, at this particular point. So number one is in our palpation, right? Right. So here they will ask you, what is massive splenomegaly? So massive splenomegaly is defined based on the size criteria. So less than 5 centimeters is mild. 5 to 7 centimeters is moderate, and anything greater than 7 centimeters is considered to be massive splenomegaly. Okay. There's also a Hackett's classification where they looked at it's graded as 1 being equal to palpable on deep inspiration, 2 is between the umbilicus and costal margin, right? So it is at the mid-clavicular line between the umbilicus and costal margin, that is grade 2. And grade 3 extends towards the umbilicus. Grade 4 is beyond the umbilicus to the pelvis, right? And grade 5 is it expands towards the pubic symphysis even. So that is a Hackett's classification, right? The normal size of the spleen here, you need to know on an ultrasound is 12 centimeters, and anything greater than 20 centimeters on an ultrasound is considered to be massive splenomegaly, right? So you need to know all those dimensions and the grading. That's something that the examiner can ask you. Okay, now you need to know what all you look for when you palpate the spleen, right? So when you palpate, you have normal palpation. So you start from the right iliac fossa and you extend upwards towards the left hypochondrium. That is how you normally palpate. Another way to palpate is through the hook method. So in this position, in this method, you ask the patient to lie down in the right lateral position, right? And then you curve your fingers under the rib cage, and there you can palpate the spleen. So that is a hook method, right? So ask the patient to lie in the right lateral position, stand on the left side of the patient, and curve your fingers below the rib cage to palpate the spleen. That is the hook method. Now, when it comes to percussion, we have mentioned a dull note in the left hypochondrium and lumbar region. So you can percussion. There are more specific signs that you can write down if you want to. That is, you can look for a dull note in the drop space, that is in the sixth intercostal space. So you start off in the second intercostal space on the left side and you percuss down to the sixth intercostal space. If the fundus of the stomach is there, in a normal patient without splenomegaly, you will get a resonant note. If the patient has significant splenomegaly, you will get a dull note. Okay, so that is how you percuss. Now, excuse me. So now we've spoken about the techniques of palpation and percussion, the grades of splenomegaly, how to classify the size, what is massive splenomegaly, etc. Right. So those are the things that they tend to ask you in this in the examination part of things. Now, another thing they can ask you is how do you differentiate a splenic mass from a renal mass? You can have the upper pole of the kidney as well in this particular area. So that's why we look for predominantly non-ballotable lesion, right? So it is a non-ballotable lesion. We are, the splenic notch has been felt. It moves with respiration. Unlike a renal mass, it moves with respiration. It is non-ballotable. The splenic notch is felt, and we cannot feel the upper border. So all these features push it in favor of a splenic lesion. So that is something they can ask you. How to differentiate splenic lesion from a upper pole renal lesion? Okay. So those are the questions that they can ask you. And one thing to note here is that when you write your palpation, all these features that I've written about the spleen are very important to put your diagnosis in favor of splenomegaly. Okay. So I hope you got all those points. Now comes your DDs. So what are the DDs for massive splenomegaly from a malignancy point of view? Don't give your benign reasons here. Only stick to your malignancies unless you're asking for trouble, right? So massive splenomegaly is seen in myeloproliferative neoplasms, most commonly as CML, a chronic myeloid leukemia. Another myeloproliferative neoplasm it could be seen in is myelofibrosis, right? Other MPNs such as polycythemia vera and essential thrombocytosis, you usually don't get a massive you can get splenomegaly, but not a massive splenomegaly. So in your MPN, most common is CML, followed by a myelofibrosis. Okay. Now, you can also get a massive splenomegaly in hairy cell leukemia. We know that hairy cell leukemia out of hepatospleno and lymphadenopathy, most commonly seen symptom is splenomegaly. So there also can get a massive splenomegaly. Another area is splenic marginal zone lymphoma, right? So it predominantly affects the spleen. That is also an indolent lymphoma where you can get massive splenomegaly. And of course, you can get it in association with your CLL, your follicular lymphoma, your mantle cell lymphoma that is, indolent, etc. So those indolent lymphomas also can get massive splenomegaly, although you can mention that at the end because that can also be associated with lymphadenopathy, right? So lymphadenopathy is also seen in those indolent lymphomas with massive splenomegaly. So that can be mentioned at the end. And beyond that, you can also, if you're getting really, you're looking at all the reasons, you can also see it in hepatosplenic T cell lymphoma. But there you'll get hepatomegaly, which is not seen in this case. So those are the list of massive splenomegaly from a malignant point of view that you tend to see. Okay, so you can say it in that order itself. Now, at this point, they can also ask you what are the DDs where you see splenomegaly with lymphadenopathy. Although it is not seen in this case, what are the DDs where you see splenomegaly with lymphadenopathy? So let's go through those. CLL, follicular lymphoma, Waldenstrom macroglobulinemia, and indolent mantle cell lymphoma. So all these BCLPDs, B cell chronic lymphoproliferative disorders, all these conditions you can get splenomegaly with a lymphadenopathy. Okay, in this particular case, we did not find lymphadenopathy. That is why we are considering this. We're putting this we're not considering this in our DDs, right? But this is something they can ask you: splenomegaly plus lymphadenopathy. So that's where you mention all these BCLPDs. Okay, now that you are moving in direction of CML, the next thing they'll ask you is, okay, how do you work up this patient? Um, now that you're suspecting a CML, right? So the workup of a CML can be divided into workup for diagnosis and staging. That is the phase of CML, followed by workup for treatment, right? So for workup for your staging, you will do, workup for diagnosis and staging, you'll do a complete blood count with hemoglobin, platelet, and total count, along with a differential count, right? So there you might get to see thrombocytosis most commonly, along with leukocytosis, right? And you can also see anemia, although you rarely get that in chronic phase. You also, on your differential count, you will see increase in neutrophils and other abnormal precursor cells for neutrophils can also be seen on DC. So once you've done your CBC and DC, you move on to your renal function tests and serum electrolytes just to see if there's any TLS, etc. That can, although it is rare and you won't see that in a chronic phase, but just in case the patient is in blast crisis, you never know. You're not certain that it's in chronic phase at this point, right? So you can do your your RFT, serum electrolytes, for also put in your LFT for good measure and your viral markers, right? So once you've done that, um, the most important thing here that you need to do is your peripheral smear. And at this point, they will ask you, what are the features you see on your peripheral smear? This is very important that you need to answer it. Okay, so you can see here, this is a peripheral smear. There's an increase in RBCs, right? That you can see in the background, which, and there are no fat spaces seen that you typically see in a marrow. So that will show you that it's a peripheral smear. So you'll do a peripheral smear. In that peripheral smear, you'll see neutrophilic leukocytosis, right? You will see a high total count and you will see a shift to left. So what is the shift to left? That is where you will see the precursor cells in the peripheral smear, right? So you'll see your myelocytes, metamyelocytes, band forms, and if it's chronic phase, you'll see few blasts as well. Okay, now in CML, out of all these precursor cells, the most abundant one will be your myelocyte. So you will have what you call a myelocyte bulge, right? That is seen. So you'll see all the precursor cells, but predominantly a myelocyte. So you'll get a myelocyte bulge. Apart from this, you will see blasts. Blasts are usually, less, usually classified as less than 10% is considered in the chronic phase. So it will be less. And you will see an increase in basophils and eosinophils, and you will see thrombocytosis more than thrombocytopenia. Okay, so all these features need to be seen. Neutrophil leukocytes shift to left with myelocyte bulge, increase in basophils and eosinophils, right? Less number of blasts, thrombocytosis are all seen. Also, you will have something called a lab score, right? Which is a leukocyte alkaline phosphatase score, and that will be less than 13. Okay, so that is something that can also be added in the peripheral smear. So now that you've done the peripheral smear, right, your next step is to do a marrow study. So based on the peripheral smear, you can ascertain the phase. Here, the blasts are less than 10%. So you can think in more in terms of a chronic phase. You need to confirm that next with a bone marrow study, right? So this is a bone marrow study. As you can see here, few RBCs as compared to, you know, uh, your myeloid origin cells. And you can also see fat spaces here, right? So in your bone marrow for a CML, what all will you see? So you'll see an increase in myeloid to erythroid ratio. Normal ratio is 2:4:1. That will be increased. You will see the same findings that you see on a peripheral smear that I mentioned earlier. That will be confirmed in the marrow. You can also see fibrosis, right? Now they'll ask you what is the role of fibrosis in CML. It is a negative prognostic factor, and it can also predict decreased engraftment after transplant. Okay, so that is just another point that you'll see there. Then blast percentage can also be confirmed in the marrow to ascertain the phase. And another thing in the marrow that is very important is you can do your conventional cytogenetics, right? So conventional cytogenetics requires you to study metaphase cells that can only be obtained in the marrow, and you can get that by doing a marrow study. So conventional cytogenetics is also very important, especially to look at additional cytogenic abnormalities. So we'll get into that soon. I'll just tell you that later on. Right. So that's how you do your marrow. Okay. Now, once you have done your marrow, you have to do something called your FISH test for looking at the presence of BCR-ABL1. Earlier, we used to look at the conventional cytogenetics. We would study, at least 20 metaphase cells, and through conventional cytogenetics, we used to look for the presence of translocation 922. Okay. Now, but that is no longer relied on. We use FISH and we use reverse transcriptase PCR. Okay, so FISH, we use a dual probe FISH to detect BCR-ABL. Okay, yeah. So your BCR-ABL gene, what is it, right? So you detect it mainly by FISH and reverse transcriptase PCR. So they'll ask you what your BCR-ABL fusion transcript or Philadelphia chromosome is. So that mainly consists of the breakpoint cluster gene, right? So BCR gene, which is located on chromosome 22. So there is a reciprocal translocation with with the gene on chromosome 9, that is your Abelson gene. And so this Abelson gene on chromosome 9 will translocate reciprocally with chromosome 22 BCR region, and there will be a ABL BCR fusion on chromosome 22, and that is called your Philadelphia chromosome or BCR ABL transcript, right? So that acts as a uh, you know a gene which gets translated into a protein that leads to CML, right? So that is the pathogenesis there. So that is something they can ask you at this stage. Now you need to know something. We'll start off with FISH, right? So that is one of the techniques we use. So BCR-ABL1 we can detect via FISH, and it is useful especially if the bone marrow is not possible due to whatever reason. If you are negative for a Philadelphia chromosome on your PCR, right? There are many atypical transcripts or various forms of transcripts that are negative on your PCR that can be detected only by FISH. That in that case, FISH is very important, right? So basically, for a atypical transcript, FISH is important, but you also, regardless of that, you do a baseline FISH. Next is you do a reverse transcripted PCR, right? And on baseline, you do what you call a qualitative PCR to detect the type of transcript. Okay. So the type of transcript is done via a qualitative PCR on baseline. Later on, to monitor the disease, you do a quantitative PCR to look at the levels of BCR-ABL1 transcript. Okay. Now, so based on the type of transcript, you have a major, minor, and micro transcript. Okay. Now, the major one is your P210 kilodalton protein. So it's called P210 transcript, which is also called your, they are either the E13A2 or E14A2 transcripts. Okay. So depending on where the break occurs. So the E13A2 and E14A2 are called the P210 or major transcripts. You also, that is what you commonly get in CML, right? You also have your E19A2 transcript, which is the P230 transcript. So that you get to see in chronic neutrophilic leukemia, etc. Okay, then you have your E9, right? Your E1A2 transcript, which is your P190 transcript. So that is seen in cases like Ph positive acute lymphoblastic leukemia. Okay, Ph positive acute lymphoblastic leukemia. That's where you get your P190. So I hope you got the different types of transcripts, right? So, so that you can find out via PCR. But some transcripts do not fall under these categories. They're atypical transcripts. Those you can find via FISH. So that is where the difference arises. And currently, conventional cytogenetics is used to look at, earlier it was a go-to modality to look at translocation 922, but currently we use it to look at additional cytogenetic abnormalities, right? So now we have done all of this. Now we have established that is CML. You do that by looking for BCR-ABL transcript. We can also establish the phase here um, uh, based on these tests. And we also look for additional cytogenetic abnormalities in the conventional cytogenetics, right? So just I'll tell you what the additional cytogenetic abnormalities are. So you have major root ones, that is isochrome 17q, trisomy 819, and additional pH positive cell. You also have minor root ones such as deletion 11q23, deletion 7q, monosomy 7, trisomy 21, 3q26 translocations, and complex karyotypes. So all these are minor root ones. So these additional cytogenetic abnormalities, you might see them rarely on presentation, but you mostly see them on progression. And they lead to inferior outcomes with your TKIs, right? So now that we have done all that, that comprises our workup for diagnosis and staging, right? So you look at your CBC-DC, you do your bio, you do your viral markers, and then you do a peripheral smear, your bone marrow studies, then you do a conventional cytogenetics from the bone marrow aspirate, and also you do dual probe FISH as well as qualitative PCR to ascertain the presence of BCR-ABL1 transcript. So once you've done that, you can ascertain this, the CML, that is CML, the phase, if it's chronic phase, and you can also look at the transcript type as well, right? So that's how you form your diagnosis. Now, you need to know the definition of chronic phase, accelerated phase, and blast phase, right? So, so classically, as per, we'll stick to there's an ELN classification, WHO classification. Follow what your institute follows. I'll stick to the WHO classification. So basically, if your blasts are less than 15, your blasts are less than 10% in total, so 10% cutoff, right? And if your blasts and pro-myelocytes are less than 30% of the total cells, and if your basophils are less than 20%, right? And if there's no additional chromosomal abnormalities, right? So all of this, if it's present, it's considered to be CP, right? And earlier you had an AP phase, which is 10 to 19% blasts, greater than 20%, greater than or equal to 20% basophils, and platelet less than 1 lakh not attributable to treatment, or greater than 1 million on treatment. Okay, so all of this came into the AP phase. And if you had additional cytogenetic abnormalities as well. Okay, so that constitutes AP as per WHO. Now, There are some, although these are not concrete criteria, there are some other features that are suggestive of AP phase. So they've used that term. Uh, this provisional factors that could point towards an accelerated phase. So that is increase in total count of spleen on TKI. If there's, you know, uh, no hematological response towards TKI, if there is occurrence of greater than two or more mutations in the um, BCR-ABL, there's occurrence of more than two or more mutations on your IRMA testing, right? So all of that can point towards an AP. So those are the provisional guidelines. Then, of course, you've got your blast crisis, where blast is greater than 20%, or presence of extramedullary disease with immature blast infiltrates. So if there's extramedullary disease elsewhere and you demonstrate immature blast infiltrates, that also points towards that, or a large foci or cluster of blasts on the bone marrow biopsy, right? So you're not seeing it on the aspect or peripheral smear, but there's a large focus or cluster of blast cells seen on the bone marrow biopsy. That also points towards blast crisis. So now the definition is slightly changed. You can also mention that the examiner pushes you. The concept of AP has now moved, we have moved away from the concept of accelerated phase, and now there's only considered to be chronic phase and blast phase, right? So that is a new development. You can only mention that if the examiner asks you, if they push you regarding it, right? Okay. Now, moving on. So now that we've looked at how to define CP, AP, and blast phase, now let us move on to the next part of our workup. That is workup for the treatment-related causes, right? Now, before you look at the treatment that you need to now Right. So you need to now stage the disease, right? You need to look at the risk of what risk category does the CML-CP, assuming that this is CML-CP, what risk category does it fall into? So for that, you have your so-called staging, which consists of age, spleen size, platelet count, and blast percentage. So low risk is less than 0.8, intermediate is 0.8 to 1.2, high is greater than 1.2. Okay. You also have your Hasford score, which is all the components in SoCal plus your basophil and eosinophil score. You've also got a UTO score, which consists of basophils plus spleen size. You've got your ELTS score, which is the full form is UTO's long-term survival score, and that consists of the same features as SoCal score, that is age, platelet, spleen size, and blast percentage. Right here, the score low is less than 1.56, intermediate is 1.56 to 2.2, and high is greater than 2.2. Okay, I focused on the SoCal and ELTS score because those are the ones that we commonly quote. SoCal was used in the pre-TKI era when you used to treat with interferon and cytarabine, whereas your ELTS score is currently used and applicable in the TKI era, right? And how is SoCal different from, or ELTS different from SoCal? So ELTS is different because it decreases the impact of age in the scoring system, right? Because TKS, as we know, it can be tolerated by even elderly people. So it is decrease the impact or the weightage for age in the scoring system. Although it has the same features as SoCal score, the weightage for age is less, right? So ELTS is currently used in the TK era. SoCal was historically used in the pre-TK era. And you also have other scoring systems such as Hasford and UTOS. Okay, so that is something that you need to know that they can ask you. So now you have defined your that is CML-CP. Also look at the risk. You can grade it as per ELTS, which is more relevant in the TK era, right? So now how do you decide your treatment? Before we do the workup for treatment, you should know what are the factors based on which you define your treatment. There are three factors, and they are in these order. Okay. So number one factor is the patient eligible, or does the patient require a treatment-free remission? That is the number one factor we look at in this day and age. There's something called treatment-free remission where you can stop the TKI based if certain criteria are met. And that is what we look into number one. Okay, that is very important. So what are the sort of patients that we go for a TFR? Those are patients who are planning for a pregnancy. So we need to stop the drug, after a certain period of time. So there also we can look for TFR. Then, of course, you have young patients, right? Young patients, we prefer not to give the, suppose someone is diagnosed in the 30s, they would not, we prefer that they don't have to take the drug for the entire lifetime, right? Which is what we do in CML-CP. So there we can attempt a TFR. Then So TFR in these two groups especially is the number one criteria we look at. Number two, we look at the risk group. So based on ELTS score, whether it is low risk, intermediate, or high risk, right? That is the number two thing that we look at. Number three thing that we look at are the comorbidities and the patient's performance status and what all other conditions he has, right? Because we know that various TKIs have various side effects. So based on that, we need to tailor it to the patient's comorbidities. So if the patient is so how does this all impact what treatment we select? The patient is looking for TFR, we prefer second generation TKIs. If the patient has a high risk score, we lean more towards second generation TKIs. But if the patient is not looking for TFRs, for example, if it's a more elderly patient, right, or is not planning for pregnancy, so in that case we can go with first generation TKI. If the patient has a low or intermediate risk score on your ELTS, there also we can go for first generation TKI. And of course, the comorbidities are also very important when selecting the TKI. We'll get into what are the side effect profiles of all these various TKIs. Okay, so that is how you decide what drug you need to give to the patient. I hope you all understood that. Now, the next point that we look at is workup for treatment. So depending on the TKI that we're giving, the workup can vary. If you're giving imatinib, if we can stick to a basic CBC and bio. If you're giving something like dasatinib, we need to rule out a baseline pleural pericardial effusion or a baseline, cardiac. We need to look at the baseline cardiac status, right? It can cause pulmonary hypertension, it can cause pleural and pericardial effusion. So you might go for a cardiac evaluation with a echo and ECG, and you can also go for a baseline chest X-ray, right? So that applies to, for example, dasatinib. If you're giving something like, say, nilotinib, you might have to do a baseline QTC, on your ECG, because it can cause QTC prolongation as well as a cardiac evaluation. You might also have to look at your baseline lipid profiles. You might also have to do your, a baseline blood sugars, because it can increase your blood sugars. So all these workups that you do, right? It's based on the treatment that you're giving. So workup for treatment is based on the treatment that you're giving, right? So based on the treatment that, the examiner puts forward a scenario. Suppose you're giving nilotinib, you need to mention the relevant workup. If you're giving dasatinib, the relevant workup. If you're giving imatinib, the relevant workup, right? Or bosutinib, the relevant workup. So all that depends on the treatment that you're giving. Workup for treatment. So I hope you understood that, right? Now, at this point, what they'll ask you is, what are the drugs that are given? And they'll ask you the various features of the drugs that are given. They'll start off with imatinib. So you need to know your DKIs for CML inside out. That is where you can score. The questions will be easy and straightforward, but you should know them, right? So imatinib is a first generation TKI, and basically it binds to the ATP binding pocket of the BCR-ABL gene, right? And by doing that, it inhibits the BCR-ABL transcript from functioning. Okay, so it is a type 2 inhibitor because it binds in the inactive enzyme conformation, right? So that is primarily how it works. Now, you take how to take imatinib. You always take it right after food to increase absorption, and you also take a glass of water, so that can decrease the nausea and vomiting, as well as GI toxicity that can be associated with imatinib. So right after food, along with a glass of water, right? You should not break the tablet, you take it as a whole, ideally. Now, you also need to look for CYP3A4 inducers and inhibitors. That is very important. You have, your inducers such as rifampicin, phenobarbital, phenytoin, right? So all these things can, cause increased metabolism, and therefore it can decrease the efficacy. You also have CYP3A4 inhibitors such as, your protease inhibitors, your azole antifungals, macrolide antibiotics, etc. All these can cause inhibition of metabolism and can increase the toxicity. So that is something that you need to look for. And this applies for all the TKIs. So I won't mention it again, but remember, this applies for all the TKIs. Now, of course, what are the indications for imatinib? Just to know this is something that, they can ask you. So of course, the number one indication is your CML CP, right? You can also use number one indication is CML. You can also use it for GIST, like we all know, in metastatic setting. You can also use it in adjuvant setting for patients who have intermediate or high risk GIST post resection. You can use it for hypereosinophilic syndrome, such as eosinophilic leukemia. There use a lower dose of 100 mg OD. You can use it for chondromas. You can use it for dermatofibrosarcoma protuberans that are unresectable. You can use it in certain melanomas with c-KIT positivity. You can use it in aggressive systemic mastocytosis, etc. So those are some of the indications for imatinib that they can ask you, because imatinib is such a commonly used drug. You need to know those indications. Okay. So now moving on. So what are these side effects of imatinib that you need to look out for? So this is something I need to counsel the examiner will ask you, how will you counsel the patient? So it can cause nausea and vomiting, right? It can cause peripheral edema right off the bat. So, it can present as, periorbital edema, pedal edema, etc. Right? You can have myalgias, muscle cramps that are very commonly seen. You can have more extensive fluid retention, like pleural effusion or pulmonary edema or weight gain, but that's rare, right? You generally just get a pedal edema and periorbital edema. Rarely you can get diarrhea, right? That can be seen. Myelosuppression can be seen. Certain patients are more prone for myelosuppression, especially if you have increased fibrosis in the marrow. You can get transaminitis, right? The LFT can be deranged. And you can also get skin toxicities. So what are some of the skin toxicities? You can get maculopapular rash. You can get lichenoid reactions. You can get pigmentary reactions. Mostly the patient's skin will lighten up. So you get hypopigmentation that you see, psoriatic rashes, right? Rare case, you can get Steven-Johnson syndrome and 10, photosensitivity. So these are all the skin reactions that you tend to see. And on long-term level, you get to see, increase in creat clearance as well. Okay, which might prompt you to change the drug as well. So that is something, a long-term side effect that you tend to see. Now, what is the data for imatinib? The baseline study was the international randomized study of interferon and STI-571. That is a code name for imatinib prior to the name coming. So that is the IRIS study. So that compared imatinib versus interferon alpha plus injection cytarabine, which is the prior standard of care. And this led to an increase in the complete hematological response, the complete cytogenetic response, the major molecular response, right? And although there was no improvement in the survival outcomes, the because most of the patients who were on interferon and cytarabine, they were transferred over to imatinib on progression, right? That's why we didn't see any improvement in overall survival. But all the parameters, other parameters were significantly improved. And also the progression to accident phase and blast phase was also significantly improved. So based on this, imatinib became the standard of care. Okay, that is the IRIS trial. So that is something that you need to remember. And one more thing is that when you monitor the BCR-ABL levels, during treatment, you use something called the International Standardized Ratio, IS ratio. So that is based on so how do we standardize reporting of BCR-ABL1? If you use the samples of the patient from the IRIS trial as the denominator, and you look at the particular patient that you're treating as the numerator. So look at the BCR-ABL levels in the baseline samples of the patients in the IRIS trial that has been taken the world over as the denominator. The numerator is the particular patient that you're treating, the level of the BCR-ABL transcript. So that ratio is used to report your quantitative BCR-ABL or PCR, which we monitor during treatment. Okay, that is another thing that we took from the IRIS trial. So that is how we came to the international standardized or IS ratio that we used to report quantitative PCR-ABL. I hope you got that. That is also very commonly asked. Now, moving on, let's move on to the second generation TKIs. What are some of the side effects of dasatinib? So dasatinib, it's got a stronger, strength of binding towards the BCR-ABL ATP binding pocket. So there you have around up to 200 to 300 times stronger binding to that particular site, which is why it is efficacious in patients who have progressed on imatinib. Okay, so once again, you need to look for CYP3A4 interactions. You would like to do a cardiac study with a baseline echo as well as an ECG and a baseline chest X-ray, because this drug can cause effusions, like we all said before, right? And so once again, doses is something that we need to look at, right? So before I go into dasatinib's doses, imatinib is given at a dose of 400 mg OD, and we can escalate the dose to 600 mg or to 800 mg in accelerator or blast phase, although now we use second generation TKIs in accelerator or blast phase, right? So you start off with 400 mg OD with imatinib. Now comes to dasatinib's doses, you start off with 100 mg OD, right? And if the patient has upfront accelerated phase, there you start off with 100 mg OD as well. If the patient progresses from blast phase to accelerated phase, there you give 140 mg OD, and blast crisis you give 140 mg OD. Okay, along with your chemotherapy, which is required in blast crisis. So those are the doses for dasatinib that you need to remember. CML CP or baseline AP, you give 100 mg OD. Progresses to AP from CP, you give 140 mg OD, and blast crisis, you give 140 mg OD. Whenever you're taking dasatinib, suppose you're taking 100 mg OD, 250 mg tablets, you take it together rather than in the morning or evening by dividing them up. Because by taking it together, you decrease the chances for pleural effusion and pericardial effusion. So that's another tip. So now, what are the side effects of dasatinib that you need to be aware of? Right? So dasatinib can cause myelosuppression, right? It can cause bleeding complications, not just from thrombocytopenia myelosuppression, but it can also decrease the function of the platelets, right? By directly affecting the function of platelets, it can cause thrombocytopenia, increased bleeding. It can cause fluid retention, mostly as pleural and pericardial effusion, right? Which we manage with steroids and diuretics if symptomatic. And then we might have to, if grade 3 and grade 4, you might have to decrease the dose of dasatinib. And you also, it can also cause GI toxicities such as gastric esophageal reflux disease. It can cause QTC prolongation, right? It can cause pulmonary hypertension. That is a very important toxicity you need to look out for in around 5% of the patients. And of course, it can cause LFT derangement. It can cause skin changes, etc. So those are the toxicity profile of dasatinib. So just remember that, right? Mainly pleural pericardial effusion, GERD, and pulmonary hypertension, and bleeding manifestations, those are some of the unique toxicities along with the regular toxicities that you see with TKIs. Okay. So this evidence for dasatinib comes from the Dasasion trial. Okay. So there they compared imatinib 400 mg OD in CML CP versus dasatinib 100 mg OD. And what did they find? There was increased complete cytogenetic response at 1 year. There's increased rates of deeper major molecular response and deeper molecular responses, right? But there was no increase in PFS or OS that was seen. Okay. One more thing was there was less conversion to AP and BP when compared to imatinib. So responses were much better and less conversion to AP and BP, although this did not impact the survival because patients post-imatinib progression were also converted to dasatinib. Okay. Now, this is based on the Dasasion trial. Now we have data. Something else that I can ask you is that we have data based on MD Anderson studies and other studies which show that you can take dasatinib at lower doses. So on a patient who doesn't tolerate dasatinib, you can decrease the dose to 50 mg even down to 20 mg. There's a Korean study which looks at the efficacy of dasatinib at 20 mg versus 100 mg. So we start off 100 mg. If they're not tolerating, even 50 mg and 20 mg is valid because we have phase 3 data for that currently. Also, sorry, phase 2 data for that currently. Now also, we can start off right away to 50 mg or lesser in patients who are not that fit as well. Okay, so that's something that you need to remember. Dasatinib works at lower doses as well, unlike the other TKIs. Okay. So now coming to nilotinib next. Nilotinib, once again, it has a higher binding affinity to the BCR-ABL pocket, right? Nilotinib, something you need to remember here is that you should not combine nilotinib with your PPIs. You should always use some other form of treatment, right? So don't combine with PPIs because it can decrease absorption. Other important thing is, once again, you have CYP 3A4 interactions. Very important is you take it on empty stomach. So you take it either 1 hour prior to your meals or 2 hours after your meals. Okay. So empty stomach intake is required to maximize the absorption, to reach the optimal absorption. Okay. Now, what are the side effects of nilotinib? That is myelosuppression. It can cause QTC prolongation, right? So QTC monitoring with ECG is required with every cycle. It can cause acute pancreatitis. So you might have to do a baseline amylase and lipase, and you might need to monitor that during treatment and always keep a suspicious eye out for that. LFT abnormalities, right? It can cause hypertension. It can cause arterial occlusive disease, and it can cause hyperglycemia and hyperlipidemia, along with your skin, GI toxicities, and peripheral edema. So those are the toxicities of nilotinib, right? So wide range of pancreatitis, diabetic patients, patients with hypertension, patients with previous signs of occlusive disease, arterial occlusive disease, all these, or patients with QTC prolongation, all these patients might not be candidates for your nilotinib. So that's something that we need to watch out for. So the data for nilotinib came from the ENEST trial, the Earnest ND trial, that they compared nilotinib. So nilotinib is given at a dose of 300 mg BD on empty stomach, and in case of accelerated phase and blast phase, it is given at a dose of 400 mg BD. Okay, so that is given empty stomach, and the Earnest ND trial showed, when you compare to imatinib, once again, deeper complete cytogenetic response, deeper MMR rates, but no survival outcomes seen, but you get deeper responses, right? So that's how this became another second generation TKI that was approved based on the Earnest ND trial. The second generation TKI is bosutinib, and bosutinib is basically, it is a second generation TKI with increased binding that is seen. It is administered with food. Okay, so that is something that's very important. Once again, CYP3A4, 3A4 interactions are seen. The dose is in CP, it is 400 mg OD. In AP and BP, it is 500 mg OD. Okay, and it's taken with food. Now, bosutinib is very important in another thing is that you must avoid PPIs just like in nilotinib, because it can decrease the absorption. Now, bosutinib is a useful drug because it can be used in patients without, with cardiac comorbidities as well as with occlusive, like, arterial occlusive comorbidities, right? So in those conditions, you can use bosutinib. So it's a cardiac friendly TKI, right? So it can cause myelosuppression, GI toxicity, transaminitis, and it can cause the other regular TKI toxicities such as fluid retention, skin rash, and of course your fatigue and asthenia. Okay, so bosutinib is special because it has less cardiac toxicities, it has less chance of arterial occlusion, but it can cause GI upset, it can cause LFT abnormalities as well as myelosuppression. So that is regarding bosutinib. That was approved in the before trial where they compared bosutinib versus imatinib, and bosutinib had higher rates of complete cytogenetic response as well as deeper molecular responses, although the survival outcomes were not improved. That's how bosutinib was approved in the before trial. Okay, so those are the first and second generation TKIs. They can ask you all these questions, so be prepared for that. You need to know it inside out. No doubts there. Right. Now, the next thing that you need to know when it comes to your CML, that is a lot of importance, is the management on progression, right? So before that, we'll just get into the responses. You need to know what a complete hematological response is. So you'll evaluate response at 3 months, 6 months, and 12 months. You evaluate response at the CBC, a DC, with a physical examination, as well as with your quantitative PCR for quantitative BCR ABL, right? You can also add FISH if it was not, the transcript was earlier not detected on your PCR. You can also do FISH. There you might need to do monitoring with FISH, right? If it is an atypical transcript, but otherwise you do your blood work as well as physical examination as well as your quantitative PCR for BCR ABL. Earlier we used to do everything, but now we can do follow up with just this as per the latest guidelines, right? So you do it at 3 months, 6 months, and 12 months. Okay. Now, there are various terms you need to know. Complete hematological response is something that you need to look at for 3 months. So 3 months, before 3 months, you should have got complete hematological response. What is that? Platelets less than 4.5 lakhs, WBC less than 10,000, no circulating myeloid precursor cells on peripheral smear, basophils less than 5%, and no palpable splenomegaly. Okay. So all that you need to, that will make sure that it is a complete hematological response. Then another thing is a complete cytogenic response. That is no pH positive cells seen, right? That was earlier seen on conventional cytogenic. So you look at no pH positive cells seen in 20 metaphases. But in terms of current era where you use PCR, that is equal to an RT-PCR score of 1% or less. Okay, that is your complete cytogenic response based on your RT-PCR score of 1%, right? Less than 1% is complete cytogenic response. Then you have MMR, which is a major molecular response, that is a PCR score of less than 0.1. Then you have MR4 less than 0.01, MR4.5 less than 0.0032, and MR5, which is less than 0.001. Okay, so know all these scores. That is very commonly asked. You monitor the patient at the 3rd month, 6th month, and 12th month, right? And it is divided into, the optimal response, the warning, as well as the treatment failure, right? So if it comes with an optimal response or warning, you can continue the TKI. If it comes with a failure, you need to change the TKI, or you need to look at what is the cause for TKI failure. So 3 months, less than 10% is optimal, greater than 10% with complete hematological response is warning. So if no CHR is attained, that is treatment failure at 3 months. 6 months, it should optimally be less than 1%, but less than 10% is also acceptable. That is comes under warning category. Greater than 10% is treatment failure. 12 months, it is optimal is less than 0.1%, but less than 1% is also acceptable. Okay, so one thing you need to remember is that treatment failure is considered if the patient has not attained less than 1 per CHR or 3 months, less than 10% at 6 months, and less than 1% at 1 year. Okay, so that is the borderline with which we consider continuing the TK or changing the TK. So 3 months CHR, 6 months less than 10%, and at 1 year less than 1%. If these features are attained, you need not change the TK. So always remember that. And then you monitor every 6 monthly, right? So now what you need to look at is if there is treatment failure. For example, if the total count increases or the patient develops splenomegaly or other symptoms, at that point in time, you need to do a set of tests. So what are the tests that you do? You do a CBC bio, a DC, a peripheral smear, a repeat bone marrow study with conventional cytogenetics for additional cytogenic abnormalities, right? CBC bio, peripheral smear, and bone marrow studies to make sure that the patient is still in CP phase and to make sure it has not gone to AP or BP phase. Okay, that is very important. Now, number one, number two is you will look at you will do a PCR for BCR ABL to look at the percentage, right? Then so that that can show you whether what is the percentage of BCR ABL1 transcript. And the last thing that you need to do is you need to look at a IRMA study, that is imatinib resistance mutation analysis. Okay, so all three features need to be looked at when you suspect a treatment failure, right? Which is usually detected rather than your blood work being wrong, usually detected on your quantitative BCR ABL, which you do at various periods of time, right? Now, I mentioned what all you do once you have established treatment failure. But before you do all these tests, the examiner will look at this point. You need to ask the patient whether the patient has adhered to his or her treatment. That is very important. Treatment adherence needs to be asked, number one. Once you have established that the patient is adhered to treatment, only then and only then you go to doing all these tests, right? So always ask that, number one. So that is what the examiner is looking for. Then you do all these tests. That is the CBC bio, peripheral smear, bone marrow studies, look at whether it's in CP state. And also you do an IRMA study to look at whether there's any mutations that so to decide the optimal next line of treatment, right? So various mutations that make it resistant to certain second line TK. So we need to look at what mutations are present, if any. So that is how you proceed. Look at adherence, then do these tests on, suspected treatment failure, right? So that is how you proceed. Now, treatment adherence is something that's very important, right? So there's an Adagio trial which looks at if the patient has around 90% treatment adherence, then the patient will have improved outcomes and can take the TK for a longer period of time with good responses when compared to less than 90% adherence. So 90% cutoff at least should be maintained when you're talking about adherence based on the Adagio trial, right? ADAGIO. So now that we looked at how to, go about it on progression, right? Now we need to look at treatment beyond second line, right? So if the patient has failed on 2 or more TKIs, so another option apart from treatment failure, another option is if the patient has developed intolerance to 2 or more TKIs, right? So intolerance is also another reason to switch TKIs, right? That is very commonly seen. For example, dasatinib with refractory pleural effusion, or nilotinib causes severe QTC prolongation, right? Or severe myelosuppression. All these things are seen on regular practice. So intolerance is also another reason to switch your TKI. So if the patient has treatment failure or treatment intolerance for 2 or more lines, right? So post second line of treatment, what are the options? So 2 or more lines, you have intolerance. or treatment failure, there you can consider the patient for allogenic BMT. Okay, so that is an option. Now, another option is post 2 or more lines of treatment. You can also look at the, excuse me, you can also look at treating the patient with asciminib, right? So asciminib is also another, a new generation TKI that has come into the market, right? So asciminib is another option, post two lines of treatment failure or intolerance. Another option is to go for transplant, right? So a CMLCP patient who is still in CMLCP, who has progressed on 2 or more lines of treatment or has intolerance, you can consider transplant. In that setting, uh, to you can give a bridge with ponatinib and then go to transplant, right? But if the patient is, say, for example, not transplant ineligible, right? Then in that case, you can consider giving post 2 lines progression. You can consider giving asciminib. Okay, so in that setting, of course, the dose of asciminib is different. It is 40 mg BD, right? That is given. Whereas in accelerated phase of blast crisis, 200 mg BD is given. So we'll talk more about that later on. So that is the indications for treatment beyond 2 lines in a patient who is still in CMLCP. Okay. Now coming to accelerated phase, they can ask you in this setting, what is the treatment for accelerated phase? So when it comes to baseline accelerated phase, there you can treat with a second generation TKI alone. You need not go for a transplant. Whereas if the patient is converted from CP to accelerated phase, there you need to give a second generation TK, make it back into CP, and there you need to consider an allogenic bone marrow transplant. Okay, so allogenic bone marrow transplant is considered in patients who have CP to AP conversion rather than in so CP to AP conversion. There you consider allogenic BMT. Whereas in patients who are baseline AP, they have a better prognosis. You can treat with second generation TK alone. Okay. Of course, the concept of accelerated phase is now being removed, but you can still mention because it's just a recent development. Most of us still stick to that classification in our regular clinical practice. So I hope you got the difference of treating baseline AP as well as converted AP. Okay. Now coming to blast phase, when you're suspecting blast phase, right? Based on your peripheral smear, based on your bone marrow studies, or based on presence of extramedullary blast deposits, right? So there you need to do a flow cytometry along with your full workup to decipher the type of blast crisis, whether it's myeloid, whether it's lymphoid, whether it's mixed, whether it's megakaryocytic, right? So based on your flow cytometry, you can decipher that. And if it is a lymphoblastic blast crisis, there you need to consider doing, right? So if it's a lymphoblastic blast crisis, there you need to consider doing a induction chemotherapy BFM90 protocol combined with your second generation TK, that is dasatinib, because it has better CNS penetration, right? So induction BFM90 along with dasatinib, once it goes into remission, there you consider doing an allogenic bone marrow transplant. Okay, post the induction phase A or phase B, right? Make it into remission and once it goes into CP, you do a allogenic transplant. In case of myeloid, you give 7+3 induction, make it go back into CP, 7+3 along with TKI, make it go back into CP, then you do an allogenic transplant. So that's how you treat blast crisis, right? Now, that is how you treat blast crisis. I hope you all understood that, right? Now, moving on, let us look at something called the T315I mutation. Okay, so T315I mutation is basically a mutation which makes the patient resistant to first and second generation TKIs. So in that T315I mutation, only two drugs will work currently that are commonly used, that is ponatinib as well as asciminib. Okay, so ponatinib, I'll just tell you very quickly, it is cannot be given on a long-term basis. It has multiple severe side effects. So we usually leave it for patients who progress 2 or more lines, who plan for transplant as a bridge, or patients who are having the T315I mutation, right? So those are the indications for ponatinib. Post 2 or more lines of treatment or patients with T315I mutation. So in those patients, you need to give ponatinib. It's usually given at a dose of 45 mg OD, right? Although even 30 and 15 mg OD can work, right? some people practically we give it a lower dose than 45 mg because of the toxicities. So what are the toxicities that are seen? Once again, you have CYP 3A4 interactions. You have, you know, you can't take it with PPIs because of decreased absorption, and it can cause a wide range of toxicity. So you can get your abdominal pain, abdominal symptoms. You can get rashes. You can get hypertension. You can get pancreatitis. You can get neuropathy in terms of paresthesia. You can have increased bleeding due to platelet dysfunction. You can have fluid retention. You can have cardiac arrhythmias, right? Atrial fibrillation. You can also have cases of MI as well. Myelosuppression can be seen. Impaired wound healing and GI perforation can be seen. Arterial as well as venous, occlusive conditions can be seen. LFT derangement, all of this can be seen. So wide range of toxicities, which is why ponatinib is given as a bridge to allo transplant where indicated, especially in CMLCP post 2 lines of treatment or more, or in patients with T315I mutation, where also you give ponatinib and then you transplant. Okay. So those are the settings in which ponatinib is given, and I hope you understood that. But due to the increased toxicity of ponatinib, now we move on to other types of TKIs. So you have something called asciminib that has come into the forefront right now. So that's based on it's a STAMP inhibitor. Okay, that is a specific targeting of ABL myristoyl pocket inhibitor, STAMP inhibitor. So it binds to an allosteric site, that is another site apart from the ATP binding pocket of BCR-ABL, right? So that is the myristoyl pocket of BCR-ABL1. Rather than the ATP binding site, it binds to the myristoyl pocket site, and it stabilizes the protein in an active state. So it prevents the functioning of the protein by binding to an allosteric myristoyl pocket site. Okay. So this can also be given post 2 or more lines of TK, especially when you're not planning transplant and the patient is not eligible or is not, cannot do a transplant, right? So that setting also can give it. There you give a dose of 40 mg BD. In the setting where there's a T315I mutation, there also you can give it. There you give a dose of 200 mg BD. Okay, so doses are different. T315I mutation give a higher dose of 200 mg BD. So toxicities here are more or less the same as ponatinib, but it has got less cardiac toxicity, less thromboembolism, less chances of MI, right? Less pancreatitis, less hypertension, less bleeding. So it is less toxic than your um, ponatinib. So that is why it is a preferred choice, right? In T315I mutations, especially if they're not planning for transplant, right? Or in patients who progress for 2 or more lines, especially if they're not planning for transplant. If you're planning for transplant, you can consider ponatinib, which might give a quicker response, but if not considered for transplant, in T315I mutations or 2 or more lines of treatment, you can give asciminib, right? And currently, one more thing I like to mention is that asciminib is now approved in the first line setting as well in CMLCP. Okay, based on the AS4 first trial. So that trial showed that you get deeper responses when compared to first and even second generation TKIs with asciminib, right? So 40 mg BD in first line setting can give you deeper responses than first and second generation TK. So that is also another option that you can give with less toxicity, right? So deeper responses, less toxicity based on the AS first trial. It is considered even in first line setting. It is approved, FDA approved currently. So although we do not do it in routine practice, it is another option that is currently FDA approved. That is asciminib in first line in CMLCP. Okay. So just a recent development right there. So now you get into, if you've answered all of this, you are in great hands. But now we get into the back end of questions they can ask you. That is treatment-free remission. Okay. Now, treatment-free remission is something that can be done in patients who have attained deep molecular responses for a particular period of time. So what are the eligibility criteria? Eligibility is basically their mandatory requirements. Just the patient should have been CML-CP on diagnosis. It should be a motivated patient, right? Who's willing to, uh, undergo, who's willing to undergo treatment, who's willing to undergo regular testing with BCR-ABL, right? So it should be a motivated patient. Patient should be CML-CP on first line. Uh, you should have high quality PCR testing with quick turnover because we require increased PCR monitoring, right? And the patient should agree to frequent monitoring. Apart from that, the patient, right, should have a typical transcript, right? So it should have a P210 transcript rather than some other atypical transcript. The patient should have taken the TK for a duration of greater than 5 years if it is first generation TK, or greater than 4 years or more if it is a second generation TK. Then the duration of deep molecular response, that is MR4 or more, should be greater than 3 years if it is MR4, and greater than 2 years if it is MR4.5. So deep molecular response for 3 years of MR4 or 2 years of MR4.5 in a patient who has taken TK for 5 years or more for first generation, or 4 years or more for second generation, with a typical transcript, right? Who has CML CPN diagnosis and a highly motivated patient with access to facility for quick PCR testing. All these factors are needed for you to do a treatment-free remission attempt. Okay, now thing is, with first generation TKI, we have the stop imatinib trial, that is the STIM-1 trial, which show that it was feasible, TFR was feasible, although the control rate is around 30% or so. With second generation TKIs, it comes up to 40 to 50% chance that you need not restart the patient on TKI, right? So that is based on the Euroski trial. So that is the data for that. Now, how do you do TFR monitoring? So you need to do TFR monitoring by doing, right, monthly PCR for the first 6 months, and then you do it 2 monthly for the next 6 months, and then 3 monthly thereafter. So frequent PCR monitoring is required. Majority of the patients will, if they will fail TFR, they usually fail within the first 6 months to 1 year. So there you can safely start the TKI again, and you can once again attain a deep molecular response, okay, in most patients. Another thing is that if the patient on TFR, right, you're monitoring the patient, if the patient has not loses their deep molecular response, but it's still in major molecular response. So anything, only loss of MMR is the criteria to stop your treatment-free remission, follow-up, right? So if you're on TFR and if you're still in MMR, you can still continue TFR. That is, you can still stay off the drug. But if you lose your MMR while on TFR, that is the only criteria to restart the drug, right? And restart, you can still attain good responses. Now, another thing they can ask you here is CML, management of CML in pregnancy, right? You need to know that the only approved drugs in pregnancy are imatinib and ilinotrib. We have data that we can use these drugs only in the second and third trimester. In the first trimester, if the patient has, leukocytosis or other, right, if the patient has leukocytosis or other issues, there you need to do leukapheresis if the counts are raised. If thrombocytosis, you might have to use low molecular weight heparin. Right? If all else fails, you can, what do you call? You can use something like your interferon treatment. So all that can be given in the first trimester. Second trimester onwards, it's safe to use imatinib and nilotinib. Dasatinib is contraindicated in all trimesters because it can cause hydrops fetalis. Okay, so I hope you understood what all drugs can be used in which all trimesters. So first trimester, avoid all TKs, give symptomatic treatment, leukapheresis, heparin, if thrombocytosis, interferons, etc. But in second and third, you can consider giving nilotinib. Data is mostly there for imatinib. Avoid dasatinib in all trimesters. Okay, so that's management of CML during pregnancy. So I hope you understood all that. And yeah, before we end, I would just like to talk about hairy cell leukemia. That's another commonly asked question. Hairy cell leukemia is a type of BCLPD. Diagnosis is made primarily with, right. So hairy cell leukemia is a BCLPD where diagnosis is made with your peripheral smear. So the patient usually present with the cytopenia or with splenomegaly or hepatomegaly. We do a peripheral smear, and that will show. This is the picture that you'll see. You'll see these cells with microvilli with these fluffy projections that you see, uh, uh, from the cytoplasm, which gives, a typical hairy cell appearance, right? You'll see a folded oval nucleus. You'll see spongy chromatin, and you'll see inconspicuous nucleoli. Okay, so those are all the features you'll see. Then you do a bone marrow, right? Bone marrow, you'll get a dry tap very frequently on aspirate. And there you'll see usually a hypocellular marrow. You'll see the hairy cells with the fried egg appearance. You'll see marrow fibrosis, right? And all this can be seen. And on IHC, what you'll tend to see is you will see positive staining for annexin A1 and TRAP. Okay. And reticulin, if there's considerable fibrosis. Of course, to diagnose it, you need to do something called a flow cytometry. Now, they'll ask you how to read a flow cytometry. So it's drawn on these charts, and based on the quadrant, you can say that the marker that is mentioned is positive or negative, right? So a particular marker is on the x-axis is positive if it is present in this area, particular marker on the y-axis is positive, it's seen in this area, and both markers on the x and y-axis are positive if the cells are localized in this particular area of the graph. So that is a simple way to how to read your flow cytometry. So this flow cytometry hairy cell leukemia, as you can see here, so the red dots represent the neoplastic B cells. So they are considered to be CD19 positive, as you can see here, right? They're CD20 positive, but CD5 negative. So the cells are localized here. And of course, they are CD11C positive and CD19 positive. So you can see they're localized in this area. And of course, you get CD25 positivity, as you can see over here, as well as CD103 positivity, you can see over here. So you said you will get the B cell marker, CD19, 20, 22, 79B. You'll also get positivity for CD11C, CD25, CD103, CD123, and CD200. It is negative for CD5, CD23, right? And yeah, so I hope you got that. It's negative for CD5 and CD23 and CD10. So that is how you differentiate, diagnose hairy cell leukemia based on the flow cytometry, which is an important component. Now, how to treat hairy cell leukemia? That is based on whether or not there's indications. So if you have 1 lakh, less than 1 lakh count, if you have neutropenia less than 1,000, or severe anemia or symptomatic splenomegaly or lymphadenopathy, there you treat hairy cell leukemia. Okay, and the treatment of choice is basically with cladribine. You give a dose of 0.1 or 0.09 milligram per kg given as a 24-hour infusion for 7 days, right? So, or you can give it as a quicker infusion of 0.15 milligram per kg given over 2 hours for 5 days. So this 24-hour infusion and 2-hour infusion, right? Earlier we used to give pentostatin, although that is not preferred nowadays because of increased toxicity. Now, cladribine, before giving that, you should some precautions is that it can cause T cell depletion, right? And that persists for 6 to 12 months. So the patient is at increased risk of infection. So always give prophylactic antivirals as well as prophylactic antifungals, including Septran if required, right, to prevent pneumocystis infections. So another thing is that you should always give irradiated blood products because there can be transfusion-associated GVHT, which can be seen. So always give irradiated blood products, right? So post-treatment, you always evaluate up at least 3 months after treatment because it takes time for the response to occur. So that is another thing that you need to remember. 3 to 6 months after only you do a repeat marrow. And another point you need to remember before we start winding up is that you also have BRAF mutated patients as well. So in recurrence, especially recurrence less than 2 years, you need to where there's a treatment indication. So just recurrence is not enough. If there's a treatment indication, if BRAF V600E mutation is there you can give dabrafenib as well. So that is another option for recurrence less than 2 years. For recurrence 2 to 5 years, you can treat with cladribine plus rituximab. For recurrence greater than 5 years, you can rechallenge with cladribine alone. So those are the indications of treatment on relapse. And I hope you also understood that treatment evaluation should be done after 3 to 6 months. Okay, so that's the treatment and evaluation and treatment of hairy cell leukemia. They tend to ask this very commonly, either in this case or they'll ask you in the grand viva. Okay. Now, another thing that you need to look at is CLL. I'll just quickly get into the diagnostic aspect of it. So CLL, what you'll tend to see is you'll see small cell. So CLL is diagnosed with your peripheral smear. There you'll see the soccer ball appearance of your small lymphocytes that are seen, equivalent size as your RBC on peripheral smear. You'll also see these smudge cells that is due to cytoskeletal deformity that is seen in your CLL cells, right? On preparation of your peripheral smear. So it's an artifact that is seen due to cytoskeletal instability of your CLL cells. Now, for a diagnosis of CLL, you need to have certain criteria that are met. So you need to have presence of So you need to have presence of these small lymphocytes at a count greater than 5,000, right? So your lymphocyte plus small lymphocyte count, your abnormal cells needs to be at a count greater than 5,000. Also, the atypical lymphocytes, or the pro lymphocyte should be less than 55%. This should be seen for a period of 3 months or more. Okay, that's when you start, consider treating it as CLL. That is the peripheral smear diagnosis. Now you also need to do a flow cytometry to make sure that the markers are there. So the CD5 positive, CD10 negative, CD23 positive, and it's also cyclin D1 negative, right? So CD5 positivity with CD10 negativity, CD20 as well as 23 positivity, along with uh, cyclin D1 negativity that confirms CLL. So you need your peripheral smear diagnosis, your count, less than 55% pro lymphocytes for a period of greater than 3 months, plus your flow cytometry markers to establish a diagnosis. So once you have established a diagnosis of CLL, you need not treat all cases. 1/3 of the cases can be followed up. 1/3 of the other cases, they can be followed up, but will require treatment later on. So 1/3, they will require no treatment at diagnosis as well as on follow-up throughout the lifespan. So 1/3 will require no treatment on baseline, but can require treatment later on. And the next 1/3, you will require treatment at baseline. So what are the conditions for treatment? If the patient has rapid rise greater than doubling of the the absolute lymphocyte count in less than 6 months, or if the patient has doubling in less than 6 months or greater than 50% increase in 3 months or less, that's the criteria. Then if you've got massive splenomegaly of greater than 7 centimeters, if the patient has got lymphadenopathy that is greater than 10 centimeters or causing organ compromise, if the patient has anemia or thrombocytopenia that is not immune mediated. These patients can have autoimmune anemia and thrombocytopenia. So make sure it is not autoimmune by doing a DCT and ICT. If it is negative, there you can consider treatment. Also, patients with no B symptoms, right? So all these features, so patients with B symptoms. So all these features are met, you can treat the patient for CLL either on baseline or on progression, right? So these features have to be met to treat the CML patient. So CLL patient. Now, another point to note here is that if you have anemia and thrombocytopenia and DCT and ICT are positive, you treat with steroids. Most patients respond. And if they do not respond on steroids, only you need to treat with CLL-directed therapy, right? So that's autoimmune mediated anemia and thrombocytopenia. You need to rule that out before treating with CLL-directed therapy. If it is autoimmune, you need to treat with steroids. Now, quickly going through the treatment choices. Nowadays, you have, you treat patients with deletion 17q as well as non-deletion 17q with proton kinase inhibitors. Proton kinase inhibitors given are, your ibrutinib was earlier given. Nowadays, we have, replaced that with other treatment options such as zanubrutinib and acalabrutinib, which have less toxicity, including less, cardiac toxicity like atrial fibrillation and hypertension, etc. And bleeding risk is lesser with the second generation proton kinase inhibitors like acalabrutinib and zanubrutinib. Right. So you can also give other treatment options such as your venetoclax plus rituximab. That is another option that is given. As compared to your proton kinase inhibitors, venetoclax and rituximab is given for a 1 year period only, so it's a fixed period, right? So that's another treatment option. And of course, you had your rituximab plus chemotherapy, the FCR regimen. That is not preferred nowadays because we have phase 3 data showing that BTK inhibitors have longer PFS and longer OS when compared to your FCR regimen, right? So FCR regimen is still given in patients, can be considered in patients with a hypermutated heavy chain, right? Variable region of heavy chain, if it's hypermutated, in those patients, you can consider FCR. Although in those patients also, currently proton kinase inhibitors are preferred. Okay, so only in patients who are young with hypermutated variable heavy chain, you can consider FCR. Only advantages, it's a fixed treatment rather than proton kinase inhibitors, which have a treatment till progression. Okay, so that's the diagnosis as well as indications for treatments for CLL as well as the treatment protocols for CLL. So it's a quick overview. I thought I'd add that to the splenomegaly case because that's commonly asked. May not necessarily be of this case, but in the rounds. Okay, and the Grand Viva as well. So I hope you had a productive session. That is splenomegaly. Know your CML-CP inside out. Know a little bit about hairy cell leukemia. Know a little bit about CLL, and that will put you in a good position to perform really well. Thank you very much. I hope you had, a productive session. Thank you.